Welcome to today's web chat on COPD. Thank you for joining us. My name is Ed Bottomley and I'll be your host for today's chat. COPD, chronic obstructive pulmonary disease, is the third leading cause of death in the US. Yet many people have never heard of it. In fact, millions of people have symptoms of COPD and don't know it. We'll be discussing the symptoms, the risk factors, and the latest therapies for this prevalent but under-recognized lung disease. So we'll meet our three experts in a moment, but first a few housekeeping items. You could submit questions for this chat at any time, even now, for our panelists to answer during the Q&A portion. Questions can be submitted by commenting on this video, but do note that if you do comment, your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can also send a private message via Facebook or Twitter. If you can't stay for the whole chat, or you want to share this recording with a friend, a video of this chat in its entirety will be up on our Michigan Medicine Facebook, Twitter, and YouTube pages. So that's the housekeeping. First off, let's meet our panelists. If we could just go down the line and have you introduce yourselves.
Yeah, hi, and I'm Doug Ehrenberg. I'm a professor of medicine here at the University of Michigan. My career focus is really on lung cancer and lung nodules, but of course, with that I come into contact with quite a few people that have COPD as well.
My name is Meilan Han, and I am also a professor of medicine in the Division of Pulmonary and Critical Care. And I run our Airways clinical and research program, and that includes caring for a lot of patients with COPD.
My name is Jose Cardenas Garcia. I'm one of the interventional pulmonologists at the University of Michigan. I have the privilege of working with a lot of my colleagues taking care of patients with COPD.
Thank you all. So I think first off, let's get stuck into the opening statement. COPD is the #3 cause of death in the US. Why does COPD fall under the radar as such a high-ranking cause of death, and why don't people know about it?
It's a really good question. I think that the burden for that falls both on physicians, but also on our the fact that we haven't done a good enough job with public awareness, so patients don't know to bring it to their physician. So I think, you know, a lot of our primary care physician colleagues in particular, they're really busy and they've got a bazillion things that they have to tackle in each visit. And unless a patient, brings shortness of breath to the forefront, it may get ignored. And I think one of the things that we see with COPD patients is they tend to limit activity levels, so they avoid shortness of breath. So they're what they do on a daily basis starts contracting, but they're not reporting symptoms. And so, I think the important message to get out there is, if you are having shortness of breath or cough or even frequent episodes of acute bronchitis that keep getting treated, that's worth talking to your doctor about whether you might have a pulmonary disease. And the only way for us to really diagnose that is to get a breathing test called spirometry. And unfortunately, that's also highly underutilized in the US. So if you're listening out there and you're wondering, you need to go in and ask your doctor about getting lung function tests done specifically, because a lot of times they'll just assume, unfortunately, that they know what's going on without doing the appropriate testing. And then we end up with problems with underdiagnosis and misdiagnosis. So I think arming yourselves, for those of you out there listening, with that information is incredibly powerful.
I like your comment about people limiting themselves. I think we ask the wrong questions sometimes. If we ask, do you get short of breath, I don't think that's the go-to question. I think that the way we should be teaching this to our trainees is to ask, are there things you don't do because you're afraid you're going to get out of breath? I think people begin to limit themselves and make their world smaller because being short of breath is such an uncomfortable sensation, and they can control it to some degree by just
not doing
dialing
anything,
back their activity, and that's a different way to acquire the same information.
Sure. Anything to add?
So I think what Dr. Han is pointing out about the pulmonary breathing test is super important. Sometimes we, as physicians, assume patients have COPD, and it's a very simple test, and actually it allow us to assess the degree of severity and as well what treatments are available for those patients. So I think it's super important.
So this is an interesting factoid. We've been, in our own clinic at the University of Michigan, have been monitoring patients coming out of the hospital who have carried a diagnosis for a COPD exacerbation. When you're taking care of a patient who's acutely ill, you're doing your best, you're using information that exists before, you're talking to the patient, and you're just kind of doing the best you can. A lot of times it's very difficult to get breathing tests in the hospital when a patient's really sick. We have found that roughly 10 to 15% of patients who are given that diagnosis in the hospital don't even have COPD when they're finally stabilized and we can get them tested. So there's, and a lot of those patients probably came in saying, well, I have COPD. So the lack of appropriate testing is a huge problem.
Thank you for this. You know what, can we take one step back and perhaps have a quick overview on
About
COPD?
what it is?
Yeah.
So that's a really good question because I think there's a lot of nomenclature out there and it gets confusing. So COPD is essentially airflow obstruction. The lungs are made out of small airways that terminate into air sacs that do the gas exchange. But if those airways become thickened, inflamed, scarred, or ultimately lost, then that ultimately leads to loss of air sacs. That's called emphysema, but the inflammation of the airways is called chronic bronchitis, and those are both part of what we consider to be COPD. So if you've been told you have emphysema, that's usually part of the COPD spectrum. If you've been told you have chronic bronchitis, that's also part of the spectrum. Now, I think another reason, and Dr. Ehrenberger, Doug here mentioned that he works a lot with lung cancer, and I think we have some of the same stigma issues for COPD that we have for lung cancer, but I think a lot of times patients say to themselves, oh, well, I smoke, so of course I'm short of breath, of course I cough regularly. Why bother even talking to my doctor about that? Because, of course, and they end up not being good advocates for themselves. It's not normal. Even if you quote unquote just smoke. And interestingly, about a quarter of patients who have COPD, and I don't remember the facts for lung cancer, so you can remind me in a minute, but roughly a quarter of the patients who have COPD have never even smoked.
Yeah.
Same for, what are the rates for lung cancer?
It's about 10 or 15% of lung cancer patients have never smoked. I always tell my patients, you don't have to smoke to get lung cancer, but it's the most efficient way to get it if that's what you want, which sounds ridiculous. And I think that we don't do a great job. We've trained generations of physicians who walk in their first day of medical school and can tell you the symptoms and risk factors for coronary artery disease. And we've trained generations of physicians who can't do the same for COPD.
Lung disease, yeah.
I also think that part of it too is that if you have a heart attack, it's an event. It's an event. Everybody knows about it. But nobody thinks of an event when they have an exacerbation of their COPD or when they begin to restrict their activity because walking the dog is too hard and they can't climb up a flight of stairs anymore, so they leave laundry downstairs. So I think there are a lot of factors. It's a harder disease to diagnose, and I think as a profession we need to do better at educating ourselves on what to look for, how to look for it, and then what prevention strategies actually work.
Yeah, one of the scary things I think about lung disease is that a lot of lung function can be lost before a patient may present with symptoms or the patient accommodates. And so, again, that's why it's so important. I think I'm sure we've all had this experience, but I've seen many patients in my clinic where they were told, oh, I might have a problem, or someone said I should go see a lung doctor, but nothing has been done. And by the time they get to me, they're actually pretty severe.
There's so much reserve built in that it's easy to ignore it for a while.
I just wanted to a little bit of clarify. How is possible if I haven't smoked, I have COPD? So there are some other risk factors. For example, if somebody who was living with you for many years has smoked and you were exposed to those fumes, right? That's called secondhand smoking. Or, for example, even my grandmother personally, right? She used to cook with wood. And she had COPD, so that's
a lot of people heat their homes with
right.
wood.
Anything
in
you
Michigan
burn
in
and
the
inhale
winter.
into your lungs. It doesn't have to be tobacco. It can
exactly.
cause
So
inflammation.
just be cognizant that be aware that
Dusty jobs,
or
certain
even
occupations,
there are some patients who can have some genetic disorders that also can lead to COPD, right? Some patients have what we call alpha-1 antitrypsin, etc. So they can also have that. So just be aware that if you have, again, shortness of breath or you're concerned that you might have COPD, ask your doctor.
Yeah, it's actually interesting a lot of the research that's going right now into COPD. We've been focusing on patients who smoke for so long, and that's important and it's good and we need to keep doing that. But we're beginning to understand that a lot of people never reach peak lung function in the first place because of childhood events, either being exposed to something or frequent respiratory infections. And so, that's why I'm critically concerned about things like vaccinations in children, about the vaping crisis among our youth. That's all going to, we don't actually hit peak lung function until about our mid-20s. Yeah. So you've got to kind of preserve that lung function as best we can to prevent adult diseases.
I'm sure you remember it better than I do, but I definitely remember that study that came out a few years ago that really changed our perceptions of certain people that have COPD. It's not because they have accelerated loss of lung function.
It's because they never hit lung high peak. Yep.
Yeah, and that, I think, really changed a lot of people's perception, but it hasn't been publicized as much as I think
we
it
talk
should.
about it, a lot in academic circles, but I think the lay public probably doesn't realize how important it is.
You know what, Dr. Han, I think you made this point in a previous web chat, and you mentioned this too. Could we reiterate the point that anything you burn, I think we were talking about bonfires in a previous chat, but...
Well, I mean, any inhaled combustible organic material has the potential to initiate inflammation in the lung and all the downstream effects that come with that, COPD, even cardiovascular disease, lung cancer in my world. People that are exposed to urban air pollution are essentially inhaling particulate matter all the time, similar to what you get with a cigarette. The difference with a cigarette is it's such a more intense volume, and it's something we can measure. It's very hard to measure urban air pollution from an individual level, but you can ask an individual how many years you've been smoking and how many packs a day do you have. And so because we can put a number on it, I think we naturally grab it. It's an easier thing to measure. But when you can't measure how someone heats their home or cooks with a wood stove, those are very difficult exposures to quantify. And I think we're in such a quantitative world now that being able to put a measure on it makes it more convenient. But we shouldn't lose sight of the fact that there are other exposures that can lead to this as well.
No, those kinds of studies have been really challenging to do. But we're definitely, I think, accumulating information that things like living near a freeway or, just all the kind of cumulative air pollution that we're exposed to, whether it's indoor air pollution or outdoor air pollution, definitely contribute to putting the lungs at risk. It's interesting when we, some of the studies that I do, we actually cut the lungs open after they've come out, say at the time of transplant. And it's always shocking to me, the lungs are a pretty good filter. Yeah. Just how much stuff the lungs have actually filtered. A lot of times the lungs they've got like little black areas in them from things that we've inhaled over time. And a lot of times that's, that the lung is there to filter. Yeah. But at some point for some patients, it becomes just too much.
People often ask me, changing the subject to nodules briefly, where did this thing come from? And I always say, I use the exact word you just did. The lung filters 10,000 liters of air every single day. And there's a lot of stuff in that air, even when you don't smoke. Even if you live on a desert island, there's a lot of stuff. And the lungs are pretty well built to tolerate that. And I think when we push the issue with cigarette smoke and urban air pollution, you're overcoming the lungs' defenses, and that's part of the problem.
Thank you for this. The next question we have up, is breathlessness the only or the main symptom?
I guess I can start with that. It's certainly a symptom, but it may not be the most prominent symptom for any one patient. So for some patients, it may be a chronic cough, it might be bringing sputum up. For other patients, it might be that they feel well, but they keep getting frequent episodes of bronchitis, and they keep going back to the doctor and being told, well, you just need an antibiotic or maybe you need some steroids to get you through this episode, but those episodes keep happening. And for some patients, that can sort of be the sentinel event or a buildup of events that can trigger for a physician that this patient needs to be tested, because having those kind of intermittent flare-ups, we call them exacerbations, can be a clue for some patients that they've got COPD.
What do you think about frequent use of antibiotics for all these episodes of bronchitis?
I think it's really tough
That's
because,
a softball.
so in general, we as physicians try not to overtreat with antibiotics, right? Because if it's just a virus, antibiotics aren't going to help anyway, and then we're just contributing to this antibiotic resistance problem. Having said that, there is data for COPD that there are increased bacteria, and some of those patients are going to need antibiotics to get through that event. And so that's where it gets a little bit tricky.
We need to get better at figuring out who's who.
Yeah.
Great. Next question. You said it was hard to diagnose. How is it diagnosed?
Here's the expert.
Yeah, well, the gold standard for diagnosis is considered spirometry or breathing test, where patients have a hard time getting their air out, and we can measure how much air they get out in that first second versus how much they get out completely. And this is a test that can be done in your regular doctor's office. Some doctors offer it, some don't. Some might send you to the hospital. The University of Michigan, for instance, has labs all over the place where we can do this. But it's actually, for the patient, it's not painful. It's pretty quick. It's not super expensive. It doesn't involve radiation. And usually can help us understand if there's something wrong with the lungs. So if you're out there and you're listening, and you yourself or a friend or family or loved one is having any breathing problems, that's usually where doctors start. That's usually that may be a chest x-ray. Now, sometimes for some of our patients, we may go on and get CAT scans, and we can talk about that a little bit in a minute, because many of our COPD patients are also at risk for lung cancer, and we're doing more CAT scans for lung cancer screening. But breathing test called spirometry is really the #1 way to get a diagnosis.
The chest X-ray help us a lot, right? Just as a screening, a part of our screening, but you can see changes, and we're going to talk about what we call hyperinflation, which is the extra air that the lung has that occurs secondary to COPD. So you're going to be able to see that with a chest X-ray. It's not mandatory. It's not part of the diagnosis, but in the majority of cases, and I think that Michigan has been leading the way, is actually using imaging to help us out to direct therapy, right?
Yeah, I think that one of the current recommendations, if you look at the U.S. Preventive Services Task Force, they do not recommend spirometry for asymptomatic smokers. But I think that takes us back to the first thing you said, which is that relying on the presence of symptoms, which we all think of as just shortness of breath or dyspnea, the word we use for it. If you rely on the absence of that as a way of not recommending spirometry, I think we need to ask the better question.
Yeah.
If we ask the questions right, there are a lot fewer asymptomatic patients out there, and those are the people who can benefit from spirometry. It helps us gauge the severity of their disease, and also, as you alluded to earlier, helps us gauge the risk for lung cancer, for instance, which we haven't talked about, but we can get to that later, I think.
One of the interesting things, I actually didn't originally intend to talk about this, but you got me thinking, was that, so we definitely know that patients with abnormal breathing tests kind of meet the criteria for COPD, but through a lot of the research that we've been doing, we've found that people who don't meet the criteria for COPD based on the breathing test still are having symptoms. A lot of doctors are just treating them with some of the same medications. Right. They're having the same number of flare-ups. They're also getting in the hospital. And if we look at them through more advanced imaging like CT scanning, we're finding a lot of the same kinds of abnormalities. And so I will say that for us as sort of a medical community, we are kind of struggling right now with what to do with those patients, and do we treat them? How do we treat them? Do we lump them into the same bucket? Do we need to redefine the disease? These are all very open questions.
People who are symptomatic, normal spirometry, but still have these changes.
Changes,
CT
CT or frequent flare-ups requiring treatment with antibiotics or steroids.
Is it airway disease or is it emphysema?
They can have both, but I think early on for all patients it tends to be a little bit more airway disease predominant, and then becomes more emphysema as patients
These are things
move
we
through
can see on the CAT scan.
Scans that aren't picked up on breathing tests.
She's really developed a lot of interest in from a research perspective is how imaging can help you subcategorize patients. We probably don't want to get too far into the weeds on that, but I think it's changing the definition of who has COPD.
Right? Yeah, one of the, Michigan, I'll I guess toot our own horn for a second here, but the University of Michigan's really, or Michigan Medicine's been really on the forefront of leading some of the advances, particularly in imaging. And so now, if your doctor at the University of Michigan, is concerned enough, and they want to see if, for instance, the patient might qualify for some of the advanced procedures for COPD that Pepe offers, for instance. We now have some pretty advanced ways of analyzing those CT images so that we can understand where the emphysema is, where the gas trapping is, which lobe it's in, and which patients are going to, potentially most benefit from that procedure. So I think that is one of the, cool things that's come out of some of the research that we're doing here.
Thank you for that. Moving on to the next question. This is an audience question. How does COPD affect the heart short-term and long-term?
Well, I can take a crack at that again. So there are actually several ways in which COPD probably affects the heart. One way is that COPD is considered what we call a disease of inflammation. So there are increased white blood cells, there are inflammatory mediators, and many of the things that go on with development of cardiovascular disease are also a product of inflammation. So it's thought that there probably is an inflammatory component to COPD that contributes to the development of coronary disease. But intriguingly, there are other ways in which COPD can affect the heart. So if you think about it, the chest cage, it's sort of fixed, right? And Pepe talked about the fact that when patients have COPD, the lungs actually get a little bit bigger, but there's only so much space between here and here. And so what happens is the heart gets compressed. And so we're finding that for patients with COPD, they have a hard time, the heart doesn't fill as well, and it has a harder time pumping. We think related, like just physically, due to less space. And so we find that when we give patients bronchodilators, which reduces the hyperinflation and allows the lungs to function better and get some of that trapped air out, it actually can improve cardiac function. And so they're very, very interconnected. If you've got really severe COPD, then when the lungs get destroyed, they also destroy some of the blood vessels. And then, the heart its job is to pump blood from the right side to the left side, but it's got to go through the lungs and then out to the body to send that oxygenated blood out. If the lungs are destroyed and those blood vessels are destroyed, then it makes it very hard for the heart to pump blood through, and that can actually lead to what we call right-sided heart failure. So there's tons of connections between the heart and the lung, and this is why it can be very difficult for us as physicians to sort out. Sometimes, I'll have patients say, well, my heart doctor said it was my lungs, and now you're saying it's my heart. And a lot of times it is both. It is for many patients.
Yeah, the pulmonary vessels are actually quite smart. When there is destruction of the lung tissue, there's going to be no great oxygenation, and therefore the vessels are going to get tighter in order to shunt, meaning to put a good amount of good blood into a good lung tissue. And that actually is going to increase the pressures of the right side of the heart, and that's what we call, at the end, many years after, the patients will have what we call right ventricular failure or right heart failure. And then the patient will get swollen, will get very short of breath. And it's actually really interesting what Dr. Han is pointed out, that COPD is just a systemic inflammatory disease. So it's very well known, for example, with patients with severe COPD have higher rates of, for example, coronary events, right, etc.
Yeah, so an adaptive response for the lungs leads to something that can be quite maladaptive with the pulmonary hypertension, and it's a late event for most patients. You mentioned this issue that the patients come to us and say the cardiologist said my heart's fine, and we say the lungs are fine. And I think the one thing that I end up talking to a lot of my patients about, again, I don't see COPD patients, but a lot of my lung cancer patients come in with COPD and they're out of breath, and it may not be the heart or the lung, it may just be muscle deconditioning too, which is where I think that's where the greatest benefits of pulmonary rehabilitation come in. We skipped a little bit here.
Patients are more short of breath, and also the inflammation.
And they stop doing what they do, and their muscles become
and that's why pulmonary rehab is so important when we take care of those patients.
Yeah, so we've got medications that we can use to treat the disease, but kind of a comprehensive exercise program that we call pulmonary rehabilitation is also usually part of the treatment plan for many of our patients.
Thank you. Let's circle back to that first question again. Why is COPD so deadly? What are people dying from? Is it a lack of care, a lack of treatment?
It's interesting because if you look across the spectrum of patients with COPD, there it increased risk for death across the disease spectrum. As you get further into more disease severity, those patients are more likely to die of a severe respiratory event. So they have a pneumonia, or they have a really severe exacerbation in the hospital, ventilator, et cetera. When you move earlier up the chain, there certainly are respiratory deaths, but there's also an increase in some of these other things that we've talked about. Cardiovascular disease deaths are actually more and more common among COPD patients, particularly those with more mild to moderate disease. So it's a whole, and then lung cancer as well. So it's a whole spectrum of things that these patients end up being at increased risk for.
The next question that we have, how is COPD tied to other diseases?
So we don't fully, so that's actually obviously a really big question. So
Sure.
I think it depends on the other disease, right? So we talked about cardiac disease, and there's all sorts of ways, whether it's those are biochemical or physical, that COPD may be related to, say, heart disease. But there's other things like sleep apnea, for instance. So we don't think that sleep apnea causes COPD or that COPD causes sleep apnea, but if a patient has sleep apnea and it's untreated, they're more likely to have flare-ups of their COPD, and treatment of the sleep apnea will help reduce the flare-ups of the COPD. It's similar to heartburn or reflux. Untreated reflux can make COPD worse and increase the exacerbation. So, I mean, I think, you know, with modern medicine, we've got cardiologists and pulmonologists, and even amongst our group, I do COPD, Doug does lung cancer, Pepe does interventional. We've even sub-split ourselves. And so I think we kind of forget that it's one body, and it's all it's all tied in.
Sure. Let's move on to our next topic, which is treatments. Can we talk a little bit about the current treatments for COPD?
So our current treatments are mostly consist of inhaled therapies. So those are inhaled bronchodilators. We've got two classes of bronchodilators available, and then inhaled corticosteroids. In the last few years, we've seen more combinations available for patients, more once daily combinations, and also different delivery devices. So different types of inhalers, more nebulized options, which are good for some patients. And that's where it's really good for patients to have a conversation with their doctor about getting the right treatment for them in the right delivery form. One of the things I think we don't talk about enough is that patients need to be trained in taking the medication correctly, because every device is different. And so I think we do our best, because a lot of times insurance controls or has some input on what we can prescribe for patients. But there are some other therapies available. There is a pill available for patients who have frequent flare-ups but also have a lot of cough and sputum production. Even though it's not currently I guess what you would consider FDA approved or FDA labeled for COPD, we will sometimes try chronic antibiotics, in particular azithromycin. There's data from an NIH-sponsored study that we did at the University of Michigan to show that can help reduce the frequency of flare-ups. But what's really exciting, and I think one of the things that we really wanted to talk about today, and while Pepe's here, is that within the last year or so, the FDA has actually approved a totally new therapy for patients with COPD, and in particular patients who have a lot of emphysema and hyperinflation. So I don't know if you want to talk about that a little bit more.
So I think I'm very proud of being at Michigan, because this is one of those few unique centers where every patient with advanced COPD or with severe COPD are discussing in a multidisciplinary fashion, right? So every twice a month we sit down with our colleagues from thoracic surgery, pulmonologists, radiologists, interventional pulmonologists, and different super specialties, just to talk about the patient and decide if the patient, yes, is a candidate for lung transplants, or is the patient a candidate for what we call lung volume reduction surgery performed by our colleagues from thoracic surgery, or is a candidate for what we call endobronchial valves. And those are called the Zephyr valves. And those valves, just going back a little bit, remember we were discussing about with COPD, the lung gets very big. That's called hyperinflation, right? So we were trying to do with the valves, which are miniature, very, very small valves. We try to put them inside the bad part of the lung, right, in order to block for the air to come out of that bad part of the lung. So good lung can be reinflated, the good lung can be expand a little bit more and can lift the pressure of the diaphragm, which is the big pump that we all have in order for the patients to breathe better. This is a minimal invasive way to actually, and has been proven already across many studies, that help patients with their breathing. They're actually able to exercise more, able to have a better quality of life, right? And the risk and the complications are small, compared to other type of interventions.
Put simply, the diaphragm works better when it's round.
Yes,
Flat.
instead of
And
being
yeah.
flat.
There's nowhere to go.
All
Yeah.
the
Right.
surgical and bronchoscopic treatments that show benefit in terms of quality of life basically have the same in common. They shrink the lungs a little bit, just enough to bring the diaphragm back into its more
Optimal
natural
functioning
round.
position, yeah.
And the reason why we discuss them is because there are patients who can do better with the valves, patients who actually are better suited for either transplant or lung reduction, or other patients that actually should be continue with medical therapy. One of the criteria that we always look, especially for the valves, is to confirm that there is no side passage of air from the lobe that is blocked to the other lobe that is actually open, right? Because in that way, if there is side passage of the air, the lung will not collapse. The bad lung will not collapse, and therefore the patient will not benefit.
I love the fact that you guys get everybody in a room at the same time to talk about this. There's absolutely no substitute for when doctors talk to one another, and that multidisciplinary approach is the best way to get the right treatment for the right patient at the right time.
Yeah,
I really love that you guys do
I think
that.
we have copy from Tumor Board.
Yeah.
Yeah.
So, it's great.
But that is the nice thing, I think, about being evaluated at Michigan Medicine is that we do have these multidisciplinary teams. So we've had lung transplant available for patients for a long time. The lung volume reduction surgery, which is like the valve procedure in that it takes that, just physically cuts out the bad lung, has also been available for a while. And now we've got the valves available. And so for some patients, one might be preferable to the other, depending on what their CAT scan looks like. And so we review all the data, the breathing tests, the CT scans, et cetera, at this conference. And then we talk about what might the best treatment option be for each patient, and then talk to them individually about what the options
And
are.
it's importantly as well to that the fact that we always meet with the patient and actually discuss benefits and risks of each intervention, right? And it's the patient is the owner, is the captain of their own ship.
Yep.
Right? So the patient actually tell us their preferences as well, and we go through, right? It's not only about doing the procedure, and I can explain benefits and risks in a minute, but actually, once you have the procedure, we continue being with you during the whole hospitalization as well as a long-term follow-up, right? Because we want to make sure that you're doing fine, and if there is any hiccup during the after the procedure, we want to be ready for you.
Great. The next question that we have, another audience question, is stem cell therapy effective for COPD?
I wish it was. Unfortunately, well, this is an area that conceptually is very exciting, right? Could we regenerate lung? And there's a lot of active and very valid research going on in this area, but there have been so many charlatans, so many pop-up shops offering stem cell therapy that, for instance, the American Thoracic Society has actually come out with an official statement on, so has the American Lung Association, on stem cell therapy, because much of what's being offered around the country, if you see something that says, we're doing stem cell therapy in COPD, unless it's part of a clinical trial, and I would encourage you to go to clinicaltrials.gov and look it up to see all clinical trials in the US have to be registered there. Unless it's part of a clinical trial, then it's not proven.
Yeah.
And anyone saying that it is lying, unfortunately. And I know our patients with COPD are desperate. I know we need better treatments. We're working on it as fast as we can. But unfortunately, most of these organizations that have popped up are offering false hope. Yeah. So that doesn't mean that there aren't some clinical trials going on at places like the University of Michigan and elsewhere that could at some point demonstrate proven benefit. But if you're thinking about it, I would just really encourage you not. I mean, these places will charge $5,000 to $10,000. They will take your money.
And a clinical trial's not going to charge you.
Right, a clinical trial should pay you probably a little bit for your time and gas money and things like that. Yeah. So if you're being asked to pay $5,000 to $10,000, that I am not aware of a single type of stem cell therapy available in the U.S., at least at this time, that is actually proven to
And this
work.
false hope doesn't come without a cost.
Yeah.
I mean, it comes with time and opportunity cost, and really we should be discouraging. I think the word charlatans you used is about the best I could come up with.
Thank you. I think that's an important question to answer there. Let's move on to risk factors. What are the risk factors for COPD and what can be controlled?
Well, we've talked about them a lot already. So there's the stuff in childhood, like making sure your kids get vaccinated, that, you know, kind of protecting respiratory health even during childhood, trying to reduce secondhand smoke exposure, reduce biomass fuel exposure, et cetera. And then in adulthood, you know, if you've got a dirty or dusty job, wearing the appropriate protections, getting your flu vaccines and things like that.
Yeah.
And then obviously if you do smoke, doing your best to quit is probably the number one.
I'm glad you brought up
advice.
flu vaccines. I wondered when we were going to, it's November and it's flu season's coming fast and furious. And, you know, how much pushback do you get from your patients when you bring up the influenza vaccine?
Yeah, I get way too much pushback, actually, particularly considering I see mostly a sick patient population, not the healthy population. So the CDC actually recommends that all individuals in the U.S. from 6 months of age to the oldest people that we have get the flu shot. But for our patients with COPD in particular, it's important because anyone with a chronic condition is at increased risk for bad things happening, like it turning into a severe respiratory infection, can develop secondary bacterial infections, and lead to death. So October is actually the month that the CDC recommends starting to get your flu shots. And the funny thing is, like, I'm so obsessed. I have a young.
Pretty fired up about it.
Well, I also have a young son, and I always make sure I've got his flu shot on the calendar like every year. And it's a little bit hard to remember too, right? Because at least for kids, they tell you when you're doing all the stuff, right? They won't let you kind of miss some of the other stuff, but the flu you have to remember. You've got to get that on the calendar. For women, just like your mammogram or whatever, colonoscopy, those regular things, it's really got to be something that gets in the calendar.
I always, when I meet my patients in clinic, it's funny because I get a lot of pushback, but I tell them that I always get sick myself with the flu almost every year because I'm doing bronchoscopy all the time. And I have had a really bad flu experience 3 years ago. But anyway, what I always tell them, and I want this to be remembered, is that Dr. Hanover already was explaining that we reach a peak of pulmonary function test, a peak of breathing capacity, and then when we become older and older, it starts declining.
We all go down with age, unfortunately.
Yeah, unfortunately, it's not because
it's
part of life.
My lung function is worse than both of yours. Right?
Most likely. I'm the young kid here. But one of the problems is with every time that you have a COPD exacerbation, if I get sick, assuming that I'm a normal person, it will decline a little bit and it will tend to recover, right? But with patients with inflammatory disease like COPD and already a damaged lung, have an inflammation or exacerbation, the decline is actually more abrupt and it tends not to recover as compared to the other normal people. So prevention is super important. And not only prevention, but also trying to quit smoking. And I know it's very hard. I know it's very hard because my dad still smokes, despite me being a lung doctor, right? He had to quit because of COPD. But what I want you also is to have a frank, you already know that it's bad, right? You have heard it, television, radio, your other doctor, your family member, right? But it's okay to ask for help, right? And please discuss this with and there are many therapies, right, that we can offer you, or your primary care physician can discuss with you and see which one is best suited for you.
Doug,
right?
you do a lot with smoking cessation. What are your tips and tricks?
Yeah, so first thing I think from a big picture point of view, what has worked well from a public health perspective is the stigmatizing cigarettes, smoking, from a public health perspective. Billboards on the highway, advertisements on TV, they work. I think if we allow that stigma to find its way into the exam room, we're doing a great disservice to our patients. So I try to make sure that when I'm working with someone who's trying to quit, that they know I'm on their side, that I don't judge them. One of the analogies that I heard from somebody else, and shamelessly stole it from them is that most people start smoking, if they're adult smokers, they started as a teenager. The tobacco industry knows this. They've targeted the teens for over a century in terms of their advertising, and I have 2 teenage sons, well, close to it. One's now 20. Your son's not a teenager yet, right? Yours aren't, but we all have been teenagers. All of us. How many teenagers do you know that make rational day-to-day decisions about their long-term health? Teens are known to be risk takers. They text and drive. They drink illegally, and they do other things that adults don't do because it's built and hardwired into their brain to be risk takers. And so making rational long-term decisions about their health is not a trait that you expect teens. So the first cigarette you pick up as a teen is an experiment. After that, it's no longer a choice. If you promote the notion that cigarette smoking is a choice, you are essentially promoting the tobacco industry's party line, and I would ask you to stop doing that. Smoking is not a choice, it's an addiction, and looking upon it as an addiction is a good way to become a little more empathic for your patients who smoke. If you smoke and you come to my office, I'm on your side. I know that it's not easy. Mark Twain said quitting smoking was the easiest thing he ever did. He did it thousands of times, and so it is extraordinarily difficult. And so we use compassion. We try to help the patient find the why. Only the patient can find their why. Once they know their why you want to quit, we can put the tools in your hands to maximize your success. And put simply, that's the tobacco cessation drugs that are out there. There are 5 nicotine preparations and 2 pills that are available. I won't go into too much detail, but they work. And I encountered, just like we encountered resistance to people getting their flu shots, which they absolutely should, I encounter enormous resistance to taking these medications. Some people look upon it as an admission of weakness, and it's anything but. It's just like saying if you're going to climb a mountain, you're going to do it with a mountain climbing guide and mountain climbing tools. You would never go out in your backyard and try to build a shed without a hammer and some nails and a screwdriver. Why would you try to do this without the right tools? It's a very difficult job. So I look upon the tobacco cessation medications that we have at our disposal as tools to achieve a very, very difficult job. So no stigma, be encouraging, help them find the why, and then once they come up with their why, give them the tools to help them succeed.
So let me ask you a very topical question, Doug.
Sure.
Do you feel that the currently available kind of mass market electronic cigarettes, vaping devices, are those something you view as part of your toolkit to get people to quit, or how do you view that?
So again, I take my cue from people who are a lot smarter than I do. I've listened to a lot of talks and discussions on this. These drugs that we have that are FDA approved are effective, but they don't work for everybody. And there are smokers who cannot quit but for the help of an electronic cigarette. And if we took every adult smoker on the planet right now and switched them to electronic cigarettes, I have absolutely no doubt in my mind that the public health impact that would be enormous and it would be beneficial. The problem is that once you open that barn door up, is the other side of the equation, is that there is an entire generation of teens that are taking up vaping that would never have touched a combustible tobacco cigarette. And that to me is the public health conundrum we find ourselves in, which is you have a tool that might potentially, the term harm reduction is used here. It's the same analogy used when you initiate clean needle programs for IV drug users, right? You know, the idea that we're giving needles away to help people shoot up IV drugs is abhorrent unless you actually do the studies and see that it actually helps people. And I think that what we don't know about right now is whether electronic cigarettes truly help people stop. There are some studies that suggest they do, and some studies suggest that they just promote dual use, which is not safer. If you are substituting electronic cigarettes for combustible cigarettes but still smoking actively, you aren't doing anything good for your health. You need to switch over completely to get off combustible tobacco. It is the killer. And eventually we need to get all nicotine-dependent people off nicotine. There's nothing beneficial about nicotine, but it's a pretty complex topic, and it's not nearly as straightforward as I think the social media would have everything be black and white. It's not.
It's definitely not. I think for me, some of the carcinogens and other things that are in many of these electronic cigarettes are of huge concern. And we don't have the long-term data.
Right.
And we also know that we've got young people who are getting sick right now.
Yeah.
So it's definitely a complicated
You alluded to
issue.
something earlier which I hadn't considered, which is what what do these things do to a 15-year-old's lungs by the time he's 25?
We don't know.
We don't know.
We don't know.
Again, if you're an adult smoker and the only way you can stop is by using electronic cigarettes, you have my support. But if you are a drugstore owner and you're selling electronic cigarettes to teenagers, you don't have my support, and you never will.
The amount of tobacco in just one Juul cartridge for et cetera,
a pack of cigarettes.
is a pack of cigarettes.
Juul pod is one pack of cigarettes.
So the amount of nicotine dependence at a very young age, the potential.
It's frightening.
It's absolutely
and it's
frightening.
this is a developing brain, and you are chemically changing your brain forever when you start using nicotine. I can't stress enough the importance of, as a teenager, this is not a mode of entertainment that you should be considering. There are plenty of good ways. Get addicted to video games if you must.
Or guitar.
Clark, if you're out there listening, I gotta tell
That doesn't apply to you.
So I think that fantastically you've answered about 5 of my questions
Oh,
in a row.
good.
So that's fantastic. Let's move on to other things COPD patients need to know. This question here, if I have COPD, am I at a higher risk for lung cancer?
I'm going to let Doug take that one.
Well, yeah, so that's an unequivocal yes. There have been a number of studies that have looked at that, both in the setting of people undergoing lung cancer screening. It is a two-edged sword because though it does increase the risk of lung cancer, it also increases the risk of screening, which is something we haven't talked about, and I don't think we want to get too far down that road, but we do know that COPD, even without a cigarette smoking history, is a risk factor for lung cancer. It's every bit as strong a risk factor as asbestos and radon, and perhaps a little bit stronger. And it probably has to do with the inflammation that triggers the COPD. Chronic inflammation in any organ has the ability to promote cancer development within that organ. That's something we've learned about every common type of cancer that's out there, and the lungs are no different. So the short answer is yes. If you have COPD, your risk for developing lung cancer is much higher. We haven't talked much about what are the causes of death in COPD patients. You talked about respiratory infections, and that brings up the importance of vaccination and washing your hands.
I mean, certainly lung cancer is a portion of it. Cardiovascular disease.
Yeah.
Stroke.
So a lot of my patients end up getting CAT scans so that I can evaluate them, say, for one of, are they a candidate for advanced therapies? But a lot of our patients are getting CAT scans now for lung cancer screening. So who are you screening, Doug? Because a lot of these, there's a lot of overlap between the patients who end up getting screened for lung cancer and the patients who have COPD.
If a patient has severe enough lung disease that they are on oxygen, for example, I don't think cancer screening of any organ
is the number one priority.
So it's hard to say this, but screening for cancer is inherently rooting for you to die from something else. We screen for breast cancer because women don't want to die from breast cancer. We screen for colon cancer because we think dying from colon cancer is a particularly bad way to die. And now we screen for lung cancer for obvious reasons because lung cancer is a bad way to suffer and die. But if you're screening for cancer, you are inherently saying, I don't want this to be the reason I die. If you already have a disease that's fairly advanced, cardiovascular disease or lung disease that renders your life expectancy on the 3 to 5 year range, then cancer screening is not for you in any way, shape, or form. It probably carries significant risk. When Pepe and I bring someone in to do a lung biopsy for something we can't otherwise exclude the possibility of lung cancer, if they have severe emphysema, their short-term risk from that biopsy is very, very high. So we always say, we do a lot of biopsies and we love doing them, but the most important thing we know is when not to, right? And
so who are you
I think that applies.
Doug?
So I screen healthy, asymptomatic, current or former smokers. And by current, I mean obviously current smoker. If you're a former smoker and you quit more than 15 years ago, right now the recommendations are that you do not be screened for lung cancer. A lot of people want to know, well, my grandmother had lung cancer, and my aunt and my brother had lung cancer, and I've never smoked. Should I be screened? And that's a scary situation, but the fact of the matter is that it's very hard to measure risk in that situation. If you're a never smoker, we have poor means of measuring your lung cancer risk. So I screen current or former heavy smokers between the ages of 55 and about 77 or 80, and there are reasons for those numbers. And again, the big thing is they have to be otherwise healthy. I think if you have a lot of cardiovascular or other comorbid disease that limits your life expectancy, then lung cancer screening, any cancer screening probably is not appropriate in your situation. That's hard to talk to because we don't want to tell people no.
Let me ask you something because I see a lot of variability on the practice of a lot of pulmonary doctors or even primary care physicians. because there are some recommendations that say, we shouldn't be screening patients who are not candidates for curative therapy, right? But you see a lot of time when CAT scans are actually not part of the screening, but hey, I found a nodule because the patient was symptomatic, and then the patient is not going to be a candidate for surgery, which is in the majority of cases curative if you have early lung cancer. Would you include those? What are your thoughts about that?
So I've listened to some good debate on this topic. We do cure cancer in people who can't tolerate surgical resection of their lung. We do with stereotactic radiotherapy. Why don't we offer lung cancer screening? And I think part of the problem is that screening for lung cancer isn't always about the people who have cancer. It's about the 97% of people who don't have cancer. So when we screen for lung cancer, your chance of actually having lung cancer is probably at the very high range, it's probably on the 3 to 4% range, which means there's a 96% chance that you don't have cancer. And where we have the greatest chance to hurt you is when we start investigating the numerous patients that have false positives on screening, and that's a lot of people. And at some point, we can't distinguish what's cancer from what's not without a biopsy. And so while that 3 or 4% may have benefited, what you've got is a large number, unmeasurably large number of patients perhaps having biopsies that have significant risk up to and including death. So when you ask why don't we screen people with severe COPD who would not be surgical candidates, again, we can go back to the clinical trial. Those people were not eligible. And one of the key eligibility criteria for lung cancer screening when the study was done that showed that it really worked was that you had to be asymptomatic. And again, we've talked about how imperfect symptoms are with respect to COPD. So I really try to make sure that if someone's going to be screened, that they've got sufficient lung function that they can tolerate curative resection, not just radiation. Now, you'll get arguments about that from other so-called experts and high-volume screening centers, but I think that they have the burden of proof is on them that they're actually doing more benefit than harm. And I think what we miss when we have people screaming that everybody should be screened is we're missing our ability to measure harm. Outside of a clinical trial, it's very hard to identify that. What you don't see, I had a gentleman email me after I wrote an editorial in the paper, well, someone did a chest x-ray in the emergency room, and thank God they did because they found my lung cancer. And I said, well, that's fine. But the letter to the editor that you never see is, well, I had a chest x-ray and they found a spot, and then they ended up doing a biopsy, and I had a pneumothorax and ended up in the ICU for 6 weeks.
And it wasn't cancer.
Nobody writes that letter to the editor. It's our job to stand up for that patient and say, don't. Right?
So I think and I have a lot of patients with COPD of varying severities, mild all the way to very severe. But and I still do some lung cancer screening even within that patient population, but it's a very individualized discussion,
Absolutely.
right? So it's
That's
talking about
shared decision
making, right? So this is what I think your risks are. This is how bad your lung function is. This is how I don't have a crystal ball, but this is kind of what I'm started thinking about in terms of are you going to die of your COPD tomorrow, 5 years from 10 years from now, what your potential risks are. So I think that really points to the fact that these are just discussions that we have to have with patients in the office.
You've done some work or tried to do some work to try to tease out just how bad COPD had to be before it became more of a dominant factor in your life expectancy than lung cancer. And I think that's an area where we could use more work. Talking to the scientists out there, if they're there, we don't have a cutoff. There's no black and white. You get into a very big gray area, and that's where I think the concept of shared decision making in the context of lung cancer screening is really important. We've built tools, online tools. www.shouldiScreen.com is useful for that, but it doesn't get to the question we're talking about here, which is how bad is my COPD and how much of a factor is that in deciding whether or not to screen.
Thank you. My final question as we try and tie this up, what else would you want viewers to know about COPD, about disease prevention or smoking cessation? As we come to a close, is there anything you think we've missed?
It's your floor.
I think I would say it's never too early to talk to your doctor, and it's never too late. There are things that we can offer early, and your disease, it's possible things are more advanced than you had thought, and that's why it's important to go in and get screening. If you're sitting out there thinking, gosh, do I really want to bring this up with my doctor? Well, it's painless. Breathing tests are painless. And but it also, if you're out there thinking, gosh, my COPD is really bad, is there any reason, why should I even bother? It's not, I would say it's not too late. I mean, we've got, at the University of Michigan, we've got therapies like that Pepe's doing, but we've also got lung volume reduction surgery, we've got transplant, and we're also doing a ton of clinical trials. More and more research, NIH funded, also funded through industry and pharmaceutical companies, is going on to try to come up with better treatments, hopefully more cures. So yeah, never too early, never too late.
A lot of things. Go ahead.
We always try to see the patient as a whole, right? Not just, we're lung doctors, but we communicate really well with other colleagues and also emphasizing the other parts. The lungs, as you can see and you heard, they don't work alone. They work with the heart. It has some repercussions about how COPD can affect your brain, the chances of cancer, etc. So we take the patient as a whole and we evaluate everything, right? And when we decide what will be best for the patient, we always discuss them in a multidisciplinary fashion and with the patient, right, who will be taking the final decision.
Yeah, I would just say the work that Milan has done in this area in terms of being able to improve the quality of life of patients with COPD has been remarkable. And so, you know, as she said, there are things that we can do that improve your quality of life, perhaps, you know, give you a chance to play with your grandchildren or walk your dog a little bit more. A lot of things that we can do to improve your quality of life. It starts with talking to your doctor, finding out if you have COPD and what we can do to improve your stamina and your overall quality of life.
I think that's the most important thing, right? About enjoying life, right? So I remember the first valve case that we did, right? The patient sent me a nice email saying that she was so grateful because now she's able to go to the games of her granddaughter.
Oh, that's great.
That's great.
Right,
That's
and she
awesome.
doesn't use oxygen anymore. I mean, that was not part of the trial, right? But
But that was a good outcome that we had, yeah.
That was an excellent outcome, right? So that's why
why
that
we're
makes
here.
me happy.
That's why we're here.
That makes me happy and everyone happy, right?
Thank you so much. So a couple of thank yous. First, to our panel of experts, thank you for your time, thank you for your expertise. And secondly, thank you to our viewers for spending a portion of this afternoon with us. And that wraps up today's chat. Thank you so much.
Thank you.
Thank you.